HealthEd is Australia's leading provider of quality clinical education for doctors and other healthcare professionals. This episode has been made available on Spotify and Apple Podcasts. For free access to the full library of podcasts and to claim CPD for listening, visit healthed.com.au or download the HealthEd app.
Today I'm fortunate to have not one but two guests, Dr. Bob Graham and Dr. Barbara Murphy, and we're going to be talking about the emotional and psychological impact of heart attack in women. Professor Robert Graham, who likes to go by Bob, received his training in medicine at the University of New South Wales and has worked in a clinical and research capacity in both Australia and the United States. After 17 years in the US, he returned to Australia in 1994 as the inaugural Executive Director of the Victor Chang Cardiac Research Institute and Professor of Medicine at University of New South Wales. Bob is a Fellow of the Australian Academy of Science, a Foundation Fellow of the Australian Academy of Health and Medical Sciences, and is a foreign member of the Royal Danish Academy of Sciences and Letters. His research has for many years focused on molecular cardiology, with emphasis on circulatory control mechanisms, hypertension, receptor signalling, and cardiac hypertrophy. More recently, though, his work has focused on cardiac regeneration and cardioprotection, with a current interest in spontaneous coronary artery dissection. Bob is the author of over 300 peer-reviewed papers, and he's also the co-founder and director of Infenza Bioscience Proprietary Limited. He's also the current Vice President of the Australian Academy of Science and the Secretary of Biological Sciences. My second guest is Dr. Barbara Murphy, who is the Associate Director of the Australian Centre for Heart Health in Melbourne. Dr. Murphy has over a 30-year career in psychosocial and behavioural research, program development and program evaluation. Most of Dr. Murphy's work has focused on psychocardiology and in particular the psychosocial and mental health impacts of cardiac disease. She's undertaken numerous longitudinal studies and RCTs investigating the prevalence and predictors of post-cardiac event mental health problems and the benefits of interventions to support cardiac patients and their families. She initiated the Cardiac Blues program, and her most recent work has focused on the psychosocial and mental health aspects of spontaneous coronary artery dissection, or SCAD. She's also involved in the management of the Australian Centre for Heart Health Cardiac Counselling Clinic, which provides psychological counselling to Australia's cardiac patients and their families, including those with SCAD. Dr. Murphy has published widely and has delivered over 50 presentations at both national and international conferences. Hello, Bob and Barbara, and welcome to today's HealthEd Women's Health podcast.
Hello, Terry.
Hi, Terry. Thanks for having us on.
Now, it's really good to have the two of you with me today to talk about the emotional and psychological impact of heart attacks in women. Diagnosis is just the start, and it's really great to take the story further with both of you today to examine the impact of heart attack after diagnosis, because I suspect many of our clinical listeners will be critical to supporting women in that process. But before we do that, can I ask you how you came, each of you, to this particular area of clinical interest? Maybe Bob first.
We came to this focus on women and heart disease somewhat serendipitously through a Q&A site that I used to run on the Victor Chang website. And we had a lovely lady from Busselton in Western Australia who had a heart attack, and she wanted to know more about it. And not much was known at that time. And so I started this program specifically on a form of heart disease called spontaneous coronary artery dissection, which causes a heart attack, although less commonly than the typical heart attacks, which are due to plaque. And then we were fortunate, after we got a number of cases and realized how important the psychosocial aspects are, to be able to link up with Barb and her colleague Alan Jackson in Melbourne. And we've been able to form, I think, a fairly formidable team to try and tease out and help people. But Barb, you might want to elaborate on that.
Yeah, Barb. So the other half of the formidable team, or the other third, can I ask about the part that brought you along this way?
Yes, Terry, thank you. Well, interestingly, I began my career in cardiac or psychocardiology actually on a very large study of women. So this was back in about the year 2000. I started working at the Heart Research Centre, which is now called the Australian Centre for Heart Health, but it was then called the Heart Research Centre. And I was invited to be part of a large study called the Women in Heart Disease Study that was funded by the Australian Commonwealth Department of Health and Aged Care. So I worked on that study for several years, and it was a large study of women, around 400 or so. And we looked at all sorts of aspects of their experiences post cardiac events. So that really set me on an early stage of my cardiac career with a focus on women. I've since then moved into looking at both men and women around their psychological and psychosocial impacts post event. And then, as Bob said, was really lucky to team up with Bob and his colleagues at the Victor Chang Cardiac Research Institute about 4 or 5 years ago, where we realised that there wasn't enough being done in the area of SCAD, spontaneous coronary artery dissection. And so we contacted Bob and his team and said, would you like us? We have expertise and work uniquely in the psychosocial area, which is called psychocardiology. Would you like us to join you in your studies and see if we can untangle what's going on for people who have SCAD, mostly women, about 95% of SCADs are in women, to see what's happening for them after their SCAD. So since then, we've undertaken a number of studies with the Victor Chang team, qualitative interview studies, a big survey. We've done focus groups. We've developed an online program for SCAD survivors and done interviews with those people. So, but we couldn't have done this without the Victor Chang group. We've sort of tagged on with them. So it has been a great team and teamwork that we've done. Yeah.
Sounds like a marriage made in heaven. Perfect. Bob, I
I
think
think it's
there's
marriage made in respect.
even better and longer lasting.
Yeah.
Bob, I think there's a widely held perception out there that stress and anxiety increases the risk of heart attacks in women. Is that true? And is the issue different for men?
Look, it only is true in women who already have underlying problems, like if they have a heavy burden of plaque disease, that is the buildup of fatty acid and cells and calcium in blood vessels, which is what is the culprit that causes most traditional heart attacks, and you have stress and anxiety as well, then that constricts the blood vessels and makes it more likely that that plaque will lift off the blood vessel. And what happens then is when it lifts off the blood vessel, it releases a protein, which is a very, very potent stimulus for clot formation. So you get a great big fat clot and you block off the blood supply to that part of the heart that's being provided with blood from that artery. In spontaneous coronary artery dissection, it's a little different. You don't have plaque. And in fact, the hallmark of spontaneous coronary artery dissection is that apart from the blood vessel that's affected, all the others look very normal. And what happens there is you get a little bleed in the middle layer of the coronary arteries, and that bleed forms what we call like a bruise, a hematoma, and it gets larger and larger, and that obstructs the blood vessel. So it's very different. Traditional heart attacks are due to a clot, whereas SCAD heart attacks are due to a bleed. And they should probably almost definitely be treated very differently. But of course, SCAD heart attacks are much less common than traditional ones. But yes, stress and anxiety can be important if you've got a heavy burden of plaque. In men, it's more likely to be physical stress, whereas in women, it's more likely to be emotional stress and anxiety.
Thanks for that, Bob. Barb, can I ask you about the emotional and psychological impact of heart attacks in women? Is it different to that we see in men? And does it vary by age group or life stage?
Yeah, that's a really good question. Well, everyone who has a heart attack or a heart event has an increased risk of anxiety and depression. So we see rates of anxiety and depression, anxiety around 40% post-event, post-cardiac event, depression around 30%. That's about 4 times higher than what we see in the community for age and sex matched pairs. So, and yes, the risks of anxiety and depression are higher for women than they are for men post-event, just like what we see in the community, actually. We see higher rates of both there. And that's due to factors like hormonal factors that exacerbate anxiety and depression. It's also due to social factors. So women post-event, they're more likely to be balancing multiple roles, caregiving, work, household, and so on. So the demands and the disruption caused by the heart attack will culminate in more stress for them. There's also delays in diagnosis, so that can lead to greater stress for women. Actually getting a diagnosis can be very stressful, so they may already have the anxiety or stress by the time they're diagnosed. And age-related factors, and you pointed to age-related factors in terms of age and life stage. So heart attacks in younger women, and about 35% of those will be SCAD, spontaneous coronary artery dissection related heart attack. They're unexpected. If they're occurring in a younger woman, it's unexpected. She's not ready for it. She's not expecting it to happen. So it creates a lot of disruption in life. And it also can lead to a lot of isolation and also stigma for women who are in that younger cohort. They don't have peers or friends or colleagues who are having the same thing and going through the same experiences. It's also misunderstood in younger women. Whereas heart attacks in older women, they're more often associated with depression. So we see the anxiety heightened in the younger, the depression heightened in the older. And that might be linked to things like physical illness, other physical illness, comorbidities, and sort of loss of independence that's already occurring in older age. And also perhaps confounded loss. An older woman might be more likely to be experiencing other losses. Women do tend to outlive men, so she may have already lost her male partner. There might be other sort of losses going on. So if it's post-retirement and so on. So yeah, it does manifest quite differently. It's more common in women than in men, and it's associated with these other sort of confounding factors.
Barb, both you and Bob have mentioned spontaneous coronary artery dissection or SCAD a few times now. Bob, can I ask you, is there a typical age when this is likely to be the diagnosis?
Yeah, it occurs in what we call relatively young women. The peak age is 45 to 52, around about the time when menopause occurs. Menopause, on average, in our society occurs at age 51. But it can, interestingly, also occur in association with pregnancy. In fact, the commonest cause of a heart attack associated with pregnancy in 45% of cases is spontaneous coronary artery dissection. They're often complicated pregnancies. Women have received therapies to get pregnant, high doses of treatments to try and ovulate when they haven't done it before, or they have had multiple miscarriages or other problems. But it can occur in association with pregnancy, usually in the first week after giving birth. There have been a few cases reported during pregnancy, but that's unusual. It's generally when the hormones we think are coming down rapidly after having delivered the baby. And similarly, in the older age group, which is the much more common age group, 45 to 52, again, when they're going into menopause and the hormones are probably coming down.
Barb, 30, 40, 50. I suspect very few women of that age would be expecting to be dealing with a heart event. Does it hold any particular emotional and psychological impact just because of that unexpected nature for those women?
Yeah, absolutely. So, yeah, it comes out of the blue. And as Bob alluded to, many of these women, or most of them, don't have very many cardiovascular risk factors, the traditional risk factors. We do see high blood pressure in some of our women who have spontaneous coronary artery dissection, but we don't tend to see a lot of high cholesterol. These women are not typically overweight. They're typically quite active, so they can be seen to be quite healthy, or they believe themselves to be quite healthy. There are some underlying causes and triggers, but it definitely comes out of the blue. So because it's so unexpected, there's enormous amounts of disbelief and shock. It can actually trigger PTSD, post-traumatic stress disorder, quite commonly. We see that more commonly in SCAD and in younger women than we do see in men and older women. And it's a rare condition as well. So because it's rare, people don't know about it. So these women are having something out of the blue, plus it's not expected. Often their health professionals won't know what it is. They haven't heard of it, perhaps. So they might get dismissed and invalidated when they rock up at emergency saying, I'm having a heart attack. They might be told you can't possibly be having a heart attack. In our work we've done with people who've had spontaneous coronary artery dissection, it wasn't unusual for them to say that they were invalidated by the people in the ambulance, by the paramedics, the people when they got to emergency, by the people in the cardiology ward, by their GP, by their colleagues, their friends. Everyone said, well, you can't possibly have a heart attack. You're a fit, healthy young woman. So it comes with shock, PTSD, confusion, being dismissed and invalidated, feeling isolated, and these things lead to a lot of anxiety and depression.
This episode is one of hundreds of informative and free clinical podcasts from Health Ed. Access the entire library through the Health Ed app for healthcare professionals, which you can download today from the App Store.
Thanks, Barb. I'm going to tease you out on that one because it sounds like many of these women are having horrific experiences. How can we best support patients who we suspect might have SCAD or have actually been diagnosed with SCAD?
There's a lot we can do, and we're getting better and better in this work that we've been doing together with Bob's team. We're getting so much information now from so many people, mostly women, but also men who've had SCAD, who are telling us what they need. They're telling us what they've been going through, and they're telling us what they need. So we're really grateful to all of them for sharing with us, because now we know a lot better what to do. So SCAD does have a fairly high recurrence rate, or it's thought to have a high recurrence rate, and it can be triggered by stress and exercise. So this leads to a lot of fear of recurrence amongst these women and a lot of uncertainty about what they should and shouldn't be doing. So the first thing we can do is we can provide validation and understanding. We can say, yes, these are real fears. Yes, this is confusing. Yes, this is difficult. Management guidelines are uncertain. We don't exactly know what advice to give, but we understand that that's very confusing for you. So health professionals need to be able to acknowledge that it's very confusing, and they need to validate these women. They also need to, where possible, refer these women to psychological support and counselling. Another factor, because it's a rare condition, as I mentioned earlier, these women feel isolated. So they need opportunities to be able to connect with their peers, other people who have had SCAD. And because it's rare, they're often geographically isolated. So that might mean bringing women together online in online groups, because they may not be able to meet up face-to-face, connecting them through Facebook groups. SCAD Research Inc. has got a great Facebook group, and that connects these people who've had this fairly rare condition. The other thing that I mentioned is health professionals aren't always aware of SCAD. They don't understand it. They're getting better, as Bob alluded to earlier, and the guidelines on management are a little unclear. So this leaves the women feeling dismissed and invalidated and confused. So one of the things that's first and foremost really is we need to better inform health professionals about SCAD, about its causes, about its triggers, who it's likely to occur in, about how you manage it, how you diagnose it, how you manage it. And in fact, we need to improve the management guidelines. So there's a lot we can do, really. It's very multifactorial. Some of that works for psychologists, some of it's for cardiac rehab, some of it's for GPs, some of it's for cardiologists, exercise physiologists. It pretty much brings in all the different disciplines who look after people with heart disease.
Thanks, Barb. Hopefully we're improving some of that today in our chat. That'd be fabulous. Bob, there's a perception, I think, that women are more likely to delay treatment. Can you outline for us all the physical and psychological impacts of that sort of delay?
Yes, I mean, it can be very, very important, because women can go from just having angina, which is a lack of blood, pain in the chest due to a lack of blood supply, to a full-blown heart attack. And when you have a full-blown heart attack, you actually lose some muscle cells. You may actually lose up to 1 billion muscle cells. And then the heart doesn't function as well. And up to 50% will go on to get heart failure, which in its worst form is worse than most cancers in terms of longevity. So every minute can count. So it's really important that they are aware of the fact that they, A, get heart disease, and that what may be symptoms they would otherwise dismiss, they shouldn't, and they should try and seek out treatment for what is and could be a severe heart attack. So it's just like a stroke, you want to get treated as early as possible.
Thanks, Bob. Barb, I believe women are also less likely to attend cardiac rehab. Do we know why that's the case?
Yeah, Terry, that's right. Again, there's another area in which women are sort of disadvantaged compared to men. Well, cardiac rehab traditionally was developed really to as a form of rehabilitation and getting men back and up and out of the hospital bed and back to work. So it's taking a long time to sort of rejig cardiac rehab and make it more suitable for women. There are a number of reasons. Women are more likely to be balancing multiple roles, as I mentioned before. So they do find it more difficult to get to cardiac rehab programs because they're likely to be going back to work, plus they've got kids, plus they're looking after older parents and so on. So it is more difficult. Second, because heart disease is less common for women, they do find fewer female peers in the cardiac rehab program if they go. So they might actually go along and then find that they're one of very few or even the only female there. So that can be difficult for them. In terms of traditional heart attacks, women are older than men. And so sometimes that creates additional barriers. They might have more comorbidities and health problems that make it difficult for them to attend. Maybe they have less social support because they're now unpartnered, or they might have more challenges with transport. But we know the evidence tells us that even older women do just as well as men at cardiac rehab. And what we see, though, is because of these older women having these features, we see a referral bias in that they're not being referred to cardiac rehab, and this is a problem. So we want to change that. In terms of heart attack due to SCAD, these women tend to be younger. So again, they might not find peers there that are, their age and female. And also often the cardiac rehab programs are typically not that well suited to women with SCAD because these women are uncertain and fearful about exercise. So they need particular guidance and support in returning to exercise. Plus, they might have few modifiable risk factors. So they might not need to learn about modifying your diet and quitting smoking. We see hardly any SCADs coming in as smokers. And so they tend to feel a bit fish out of water at cardiac rehab. And that's a bit true for women generally. Women generally find the exercises at cardiac rehab can be a bit challenging because they're a bit treadmill and weights oriented. But we're getting a lot better. Cardiac rehab programs are really starting to incorporate other forms of exercise like Pilates and yoga, dance, all sorts of things like that, that may be more suitable for women instead of just the old traditional way. Or they might offer options, but not all cardiac rehab will do that. But again, these SCAD women are less likely to be referred. So we're seeing that non-referral bias again. So as I mentioned, the research shows that cardiac rehab is just as good for women as it is for men, even if they're older. And there's more and more research coming out now showing that even for women who've had spontaneous coronary artery dissection, cardiac rehab is safe and effective. So health professionals don't need to have these referral biases or concerns about referring either older women or younger women. And cardiac rehab health professionals are starting to do better to either sort of modify their cardiac rehab program to make it more suitable and also stagger entry of women so that women might be coming together at the same time. So we're doing all that we can there, but yeah, definitely a challenging space, that's for sure.
I might mention also, Barb, if you don't mind, that
Please.
as you mentioned, that they feel a little bit like a fish out of water. They've got a bunch of old men ogling at them while they're doing these exercises, and they don't feel comfortable. So we're trying to. We haven't got the money yet to do it, to develop specific rehab programs designed for women with these problems, so that they can feel comfortable. And I can tell you over and over again, the ones who do it They really appreciate it, and they do very, very well. And the other problem we have is somewhat has to do with our geography in Australia. If they're from a regional area, rural area, they often don't have cardiac rehab available to them. So they have to travel long distances to get to there, and that also precludes them from having cardiac rehabilitation.
But I'm gathering from both of you, if it's done well and if it's focused on women's needs, it sounds like it would be invaluable. Is that right?
Very valuable.
Absolutely.
We need to make some differences, it sounds like.
Mm.
Bob, if I was to ask you for the key messages that you'd really like to get out there to our listeners about supporting women after a heart attack, what would they be?
I think Barb has really summed them up so well. I mean, we have to validate the fact that these women have gone through a major medical problem, and that the symptoms they're getting, both psychological and non-psychological, are real. And we have to learn as doctors to recognize them and to help them with that in a way that only people like Barb and her team can do, by providing the sort of support, the recognition, and the validation of their problem.
And Barb, if I was to get you to wave a magic wand and improve things, where would those improvements take place?
Yeah, I think I totally agree with what Bob said there around the validation, improving that recognition. I suppose I would summarize it in two key words. We need to get better at identification of mental health problems post-cardiac event. So that's meaning introducing screening for anxiety, depression, PTSD, other forms. Sometimes you don't have to do formal questionnaires. You can just ask, how are you going? How are you traveling? Might be just a simple word. If you don't have time, your facility doesn't have time for formal screening. But we need to get better at identification at every opportunity. And that includes general practice. In general practice, it includes cardiologists doing it as well. Not just in cardiac rehab, we're getting pretty good at doing it there. The other thing is referral. We need to, once we've identified someone at risk of mental health problems, we need to know when and how to refer. So you might not refer on the first positive screen, but you might go for a second one. And then you need to refer them to a specialist psychocardiology clinic like the cardiac counselling clinic that's currently being run through the Australian Centre for Heart Health. And there are others. But it's great if a person with heart disease post-event experiencing mental health problems has a counsellor or support person who actually understands the heart disease, so they don't have to tell their story 1,000 times over, and that the person understands the type of experiences they're likely to be going through. So yeah, identification, referral, and then just improving overall management, I think, Terry.
Thank you. Now, we're getting pretty close to the end of the podcast, but do either of you have any really good resources or websites that you'd recommend to our listeners who might want to explore the topic in more depth or refer people on for information?
There's lots been written about this now. We're becoming much more aware of the specific issues that women experience when they have heart problems. And two I can recommend. The one is the Australian Heart Foundation, and that site, and maybe you can put that up in your podcast, is www.heartfoundation.org.au, and just go to the section on women and heart disease. And the second one is the American Heart Association, and that goes by the strange name of www.goredforwomen.org. And the reason for that is that the Go Red has been a moniker that they've adopted years ago to try and increase awareness of heart disease in women. And they wear little red badges around the time of American Heart Association meetings. So it's a nice way to highlight the importance of heart disease in women.
Bob, I'll absolutely be sure to put links to those on our website so people can get to them easily. Barbara, do you have any you could add?
Yes, well, in addition to the cardiac counselling clinic at the Australian Centre for Heart Health, I would also like to refer people to SCAD Research Inc. So that's www.scadresearch.com.au. They've got terrific lot of resources for people who've had SCAD and their family members and people who support them, including links to various other supports and services and so on as well. So I think that's a good first one-stop shop for SCAD related stuff, as well as, of course, the Victor Chang Cardiac Research Institute's website as well. Have really great stuff too.
Barb, I'll put those on our website as well.
I
Bob.
should actually acknowledge the SCAD Research Inc. is run by Sarah Ford, who herself has had a SCAD, and she's been an absolute angel in putting this together and getting people to talk to each other and to comfort each other and to learn about SCAD. They even raise important money so we can do research. They have a walk every year called a group called the Skedaddles, and it's critical because it's hard to get funding for some of this research.
We certainly need more champions in this world, so good luck to her. That sounds brilliant. Barb, thank you for sharing your time today, your insights and your expertise with us all. It really has been an absolute pleasure chatting to both of you, so take care.
Thanks very much for having us.
Thanks, Terry, for having us.
Thank you for listening. Visit healthed.com.au to create a free account and claim CPD for podcasts like this and access a record of your learning. Subscribe to the show on Spotify or Apple Podcasts for weekly episodes on a range of clinical areas relevant to your ongoing practice.